You're on. There we go. So welcome back, everybody. I know I do see the list is a little bit thinner than it was, so congratulations on making it through from last semester to this semester. It's actually a really big deal. I think this semester is a little bit, I think it's less heavy than last semester, honestly. The big ones from last semester are like inflammation, and then all those fluid and electrolytes and stuff. We don't have anything that confusing this semester, as far as, I mean, I don't think so. And then there's a few pretty easy weeks in there. There's a couple of like Karen and I were just talking about, like, there's like one on obesity and metabolic syndrome, and then diabetes isn't too bad. That's not a really heavy week either. So I think you'll find this semester a little bit, I don't want to say lighter, but it's just not as intense as last semester. So that's awesome. How are you guys? You already had your class on stroke, right? I'm not like ahead of the teacher, correct? Yes. Oh, hi, Darla. What days are your what days are your classes this semester, guys? For this, like patho. Just so I know. Tuesday, Ashley's Tuesday. Is there only one class, maybe? You have Wednesday. Okay, so there's at least two. Okay, awesome. It's just so that I don't post. So I started working with mind maps a little bit. I just don't want to post them ahead of your class, as I will get in trouble for doing that. So I'm trying something a little bit new. Kieran had done those awesome mind maps last semester, and I thought they were really awesome. So I'm kind of giving it a try. You guys can let me know if it's just more confusing or if it's helpful. I just feel like you get those PowerPoints and you get your textbook and everything's really wordy. Like, it's just paragraphs and paragraphs and paragraphs, and then maybe having things a little bit more visual will help you just to remember for your exams. All right, so let's talk about stroke. Oops, sorry. I'm a little bit, I'm having a little bit of a hard time getting used to this, sharing this screen like this, so just bear with me. So a stroke really is some kind of interruption in the blood supply to or within the brain. So, and I'm sure you've gone over this, we're talking either some kind of clot that's stopping the blood from getting there, or a hemorrhage where basically the vein has, or not the vein, the artery has burst, and the blood is not getting where it should be, and it's filling up the cavity, right? The space that holds the brain, which we'll talk about next week. So before we get into like too much of the patho, I just wanted to kind of go through the signs, because these are the things that I find come up on exams that are a little bit tricky. Like remembering, first of all, remembering, like, if you look at all these words, if you've never seen them before, things like, hemianopia and aphasia and dysarthria, like those can be, they'll come up in an exam and the whole question is shot if you don't know what it means, right? Also the whole left and right thing, like what's happening on each side. So let's just go through it really quickly. Signs of an acute stroke, right? You've got the sudden onset of kind of a weakness in arm, usually on half of the body, arms and legs. When it says unilateral, that's what it means. It's on one side. Vision loss on one side. Language disturbance is a really big one. People, usually it's like a slurred speech. If you've ever had any patients who've had a stroke, or if I've actually seen somebody like out in public, like having a stroke, they were talking and it just kind of like all of a sudden their speech just kind of went and half their face went slack. It was really very obvious that it was happening. This hard time balancing because one side basically isn't working properly. So these words here, I know I've gone through this with you guys before. Anytime you see A like that, it's going to be no or none. So anuria is no urine. Ataxia means movement. So anytime you see that is ataxia, is no or difficulty with movement. Anytime you see hemi, we're talking half. Opia is always referring to the vision or eye. So hemianopia is vision loss in one eye. There's a couple of tricky ones with the eye we'll go over later. Impaired motor skills, of course, and then we'll talk about the difference between a TIA and a stroke a little bit later. But the big thing that you just have to remember is that a TIA, basically your symptoms will resolve on their own without any like intervention. People often will have TIAs and not even come into the hospital, not even know that they've had them. They just have like this weird feeling, and then it goes away. They don't even call their doctor, some people, which I would, because I'm a bit of a hypochondriac. So, and again, yes, your specific stroke signs are going to depend on the specific area compromised. Again, it's tricky, and you just have to memorize, which part of the brain is responsible for what. This here actually showed up on one of my exams once and really tricked a bunch of people. They missed the question. So just so you know, agnosia is the ability to recognize people's faces and objects and voices. So you'd be looking at a pen and not know what it is. So just kind of keep that in mind in case it shows up on something, and then this we'll talk about later. It's just there for you when you're studying. Okay, so let's talk about the right and left. I'm sure your prof told you that when you have a stroke on the right side of your brain, it affects the left side of your body. And the same if you have a stroke on the right side of your brain, it affects the left side of your body. So really, what you have to do is kind of look at this. So what I did when I was studying is I kind of memorized what was on the left side, knowing it's all these kinds of like logic, language, and math, like speech, and then kind of left the rest of it, like the right side. And you've heard this before, right? The right side is creative, the left side is logical or whatever. Just kind of like memorize the left side, and then any question that came up that didn't relate to that, I just assumed it was the right side, and that worked. It worked fairly well for me. So if you just kind of go, the left side is much more analytical processing, skilled movement, very logical. Then the right side is going to be all your abstract things, your like interpretation of the things that you're seeing, your creativity, and of course your emotions, basically most of your emotions anyway. So you're not going to be able to you're just not going to be able to know these things, all of them. But they tend to make them fairly clear on an exam. Like, I don't know if you found that, Kieran, but like, it's usually like, if they're going to ask you a question, it'll be like language, maybe spatial, perceptual, like it's things that are fairly obvious. So don't go crazy trying to memorize all of that. Again, over here, when we're looking at kind of the anatomy of the brain, and the only reason this matters is because in a stroke exam, they may, like a school exam, they may ask you, like the patient had a stroke in the frontal lobe, you would expect to see this, and this. So if you see these little yellow dots here, I kind of use those to highlight things that I've seen come up over and over and over again on exams. So if you want to use this just to have an idea when you're studying what to focus on, because this is a lot of words to remember, right? To try to remember what goes where. I wouldn't bother memorizing this. Just kind of have an idea. And like I said, if you go with the yellow things, you should be okay. Obviously, you're going to know that your brainstem is your, like your reticular activating system, like those things that breathing and heart rate control, all of that's in your brainstem, right? You guys know that. They do tend to ask a lot about balance and motor movement. Just know that it's your cerebellum. And I'll leave the rest of that with you. You guys can go through that. Just a little bit of anatomy overview. Really you know, okay, so you've got these carotids, right? This is where the blood comes from your body, right? It's pumped up through your aorta into the brain. So you have an internal, external carotid. And then if you look down here, you can see them kind of where they come out in the brain here, in the middle of what's called the circle of Willis. It's just kind of where all of those like arteries are meeting, and you can see that it's kind of a circle like this. And what that does is it offers an opportunity for what we call collateral circulation. So if something happens in a, you know, here, and normally it would cut off the blood flow to this like whole area, but the blood can actually go around, can actually go around and find a different way to get to the brain. So it's really quite brilliant in a person's ability to kind of like find a different way. The body's ability to do that will determine the severity of the symptoms and the stroke, right? We'll look at that again a little bit more later. So let's talk about autoregulation. This is good because it's going to come up next week as well in your brain injury. So the brain cannot store oxygen or glucose. Okay, it's really important. That's why I put all these squigglies here, because it'll come up for sure. So your brain can't store those things, but it obviously needs them for metabolism, for cellular metabolism, right? And so we need a constant blood flow. We need blood constantly coming in and circulating through all of these capillaries and sending blood to all of the cells. So the problem is the systemic blood pressure is really influenced, I guess, by so many other things. You guys know this, right? You get excited, your blood pressure goes up, whatever. So the brain's circulation basically is on its own. It's regulated on its own, separate from the body. And what that means is that we have a consistent blood flow through the brain regardless of any changes in the systemic pressure. So if your blood pressure goes way up because you're nervous or you're whatever, it's not going to change your brain's ability to get what it needs. So, and this, you don't really need to, like, it's just kind of an idea. This is a good thing kind of to so part of the way that the brain will do this is when your systemic blood pressure goes up, right, the cerebral arteries will constrict. And that means that all that blood flow that's going up those carotid arteries is going to hit kind of resistance getting into the brain. So it's going to keep the brain blood flow flowing, you know, at its whatever rate. And then the same goes for when systemic blood pressure goes down. Those arteries will dilate so that the blood that's coming up has a nice open like space to go through and fill the rest of the brain. Sometimes I look at these after, I'm like, why was I drawing a squiggly line? Sorry. Okay, so there are these three major players affecting blood flow, right? You have your oxygen, carbon dioxide, and hydrogen ions. Carbon dioxide, just so you know, because it's going to come up, I put it here, it's going to come up again. It's a very, very potent vasodilator. So when you have conditions, for example, like COPD, where you're holding a lot of carbon dioxide in the body, it causes all of your veins to it's very, very potent vasodilator, and it does can affect the cerebral blood flow. We'll talk about that a little bit more later because it's a little bit confusing next week. So I know that your teacher probably hit on this, the difference between hypoxia and ischemia. I'm just going to flip over. Sorry, if you guys have questions, just I'll keep checking the chat. I just have to click to a different screen, but I'll keep checking it here and there. So when we say hypoxia, again, oxia, obviously we're talking about oxygen or a lack of oxygen. So while the blood is getting to the brain, there isn't enough oxygen in that blood. And so then obviously the the neurons need that oxygen to function, right? And so they'll have to begin performing this anaerobic metabolism. Unfortunately, that anaerobic metabolism, which is just the body breaking down other things in order to keep the cellular metabolism going, to keep those neurons firing, it only lasts about 4 to 5 minutes. So this is basically how long your brain can last without oxygen. Then it will fail and we will have all kinds of stuff happening, which we'll talk about in a second. Sorry. And then ischemia. So instead of a lack of oxygen, now we have a lack of blood. Because blood carries oxygen to the brain, that means you're also going to have a lack of oxygen. But you're also going to have a lack of everything else that the blood carries to the brain. So you're going to be low in glucose as well. The brain counts on, all cells count on the blood bringing them their oxygen and glucose and then taking away any metabolic waste. And when your blood flow has stopped, so I'm just going to use this over here, but let's say you have a clot here in your carotid and nothing is getting through to your brain, not only are you not getting oxygen and glucose, but the brain isn't able to remove any of the waste from the cellular metabolism that's going on right now. So try to remember these numbers. Again, you'll recognize them if they show up. You don't have to like memorize. You'll recognize you have 4 to 5 minutes without oxygen. The oxygen that is in the brain already circulating will be depleted within 10 seconds. And then your body will switch over to anaerobic metabolism. Your glucose can last a little bit longer. The glucose that's already in the brain takes 2 to 4 minutes for it to be depleted, and then you're in trouble, right? So, and again, if you have, for example, a TIA where that blood flow is blocked, but it's blocked temporarily, and it kicks back in, within a few minutes, your body will just kind of adapt, and the blood will go through, and you won't have any like long-term damage. But if that ischemia lasts longer, okay, you will end up with, permanent cellular injury, right? And so I don't know how, Darla, you had said that your prof hadn't been super concerned with all that was happening with the cellular. Does that mean you don't need to go through this whole ischemic cascade? Or anyone can answer, actually. If you guys are there. You're fine. I know, well, you're maybe fine, but I just want to make sure, like.
I remember asking about ischemia, like going through this ischemic cascade. I remember studying it. I don't remember if it was on the exam. Yeah, it's part of the objectives.
Okay, let's go through really fast then, just to kind of have an idea of what's happening. Thanks, Karen. So this whole process that we're about to go through now is called the ischemic cascade. Okay, so honestly, the really important part is this kind of calcium stuff we'll talk about. But so the cells aren't getting any oxygen, they're not getting any glucose. They need that for cellular metabolism, and because of that, they're not releasing any ATP. Remember, adenosine triphosphate. That's our energy, basically, right? So if our body's not creating that, it's going to start metabolizing without oxygen. right? So it kind of breaks up, it doesn't really matter. What's important here is that when we have anaerobic metabolism, this is going to come up again. It releases lactic acid into the system. Okay, that will come up again, so just kind of have an idea. But what it does here is it causes your neurons, your cells to depolarize, causes your ion pump to fail. We talked about this kind of potassium-sodium channel last semester. So what's happening here is you've opened up this channel. All of your sodium and calcium are coming through, but they're not leaving. They're not leaving. And so what happens is you get this buildup of calcium in the cell. That extra calcium triggers this glutamate release. This is actually, I'm pretty sure this has come up on my exams. I don't know about you, Karen, but this whole concept of glutamate's important.
Yeah.
So glutamate is just an, yeah? It does. Okay, so glutamate is just an amino acid, okay? And it's part of its job is to kind of, it's involved in the process of the signals jumping through the synaptic cleft, right? From one neuron to the other. So it's already in your system, it's doing its job. Unfortunately, when calcium triggers this higher release of it, it causes this, excitotoxicity, I guess is what we're calling it. And so what that does is it stimulates those receptors that are on the cell to allow even more calcium into the cell. So it's kind of this like vicious cycle that's just, right? I don't know that you need to know this. It was in your notes. I just scribbled it down. I'm guessing not. So it's there if you want to look at it later, but I'm not going to focus on it now. What's really, really important is understanding what this glutamate is. So it's the most abundant excitatory amino acid, okay? And the biggest thing that it does is it excites the cells to the point where they start to release these other chemicals, your arachidonic acid, free radicals, nitric oxide, and eventually what they do is they cause this mitochondria to break down. And the mitochondria inside of each cell releases toxins and apoptotic factors. And you remember that apoptosis is the like the death of a cell, right? So that's actually what causes the cell to die. So this whole ischemic cascade, it begins because of a lack of oxygen and a lack of glucose and what have you, basically blood to the cells. The cell begins to break down other things, releasing lactic acid, all of this calcium. This is the key part, is the calcium going into the cells and not coming out, because that's triggering that glutamate. And then the glutamate is basically what triggers this mitochondrial breakdown and the apoptosis, and the cell dies. So I don't know how how you guys are with, if you remember your inflammatory stuff, but during this you have injury to the brain, right? And so your body is going to release those inflammatory mediators. You remember those from back in the day, your histamine and prostaglandins. They're going to rush to that site, and what they do is they call, if you remember through chemotaxis, they call those white blood cells to come and fix the problem. But what the white blood cells do is they come and they engulf the damaged neurons and the damaged particles that are left over from this whole process here. Unfortunately, it kind of breaks it down. You remember how those inflammatory mediators, how they cause the pus and the breakdown of your neutrophils and all of that. So that's all happening, and it basically causes this thing called liquefactive necrosis, which is basically your cells turning into a gross liquid. You don't need to know, like, you know, they're digested by their own hydrolysis or whatever, but it walls off from healthy tissue and can become a cyst or an abscess. And that's just how all this is telling you is how like stroke inflammation plays a role in that cellular necrosis. So not only do you have these, cells dying from all of this, you have cells dying from this. So result of the, so 6 to 12 hours, your brain tissue begins to soften, becomes discolored, and within 72 hours you end up with this kind of swelling and mushy disintegration. And if you look down here at this is not something you need to memorize, it's just something to help you understand. Do you remember those neutrophils and macrophages bouncing along here? Remember, they roll with the selectins and integrins, they come out and then they attack that those damaged neurons. So that's really, if you get a question that's asking you about how inflammation plays a role, that's really all it's trying to explain to you. This concept of the penumbra and the core is quite important. So the core of a stroke, I lost my little guy. So in this picture we have here, this right here is where the blood has stopped flowing. This is where there's an occlusion, something has happened. And you can see after these are all like a different color, right? So the core is the area around this occlusion. This is the occlusion that is most affected by that cutoff of blood supply. Now, the size of that core, where that damage is the worst, it's going to be affected by this collateral circulation. If you look over here at this, if you have, again, so just imagine this like kind of picture here is what we're looking at here. So you have this clot here, and there's very, very little collateral circulation. There's no way for that blood to find another way here. So that core, the damaged part, is quite large. If you look over to the second example here, where you've got the clot in the same place, but you have all of this collateral circulation kind of going around it, look how small the core is now, right? So that's what I was saying earlier about people who have a good collateral circulation kind of system are much less likely to have large areas of permanent damage, because this ischemic core here, this core is untreatable. Those cells have died. They are not coming back. Now, the penumbra, which is just I call it penumbra, it might be penumbra, I don't care. It's this area that you can see on the outside. It's shown here as well on this collateral circulation. It's a larger area around that core that is potentially reversible. This is what we're trying to treat when a patient comes in to emerge with stroke symptoms. This is why we ask immediately, when did you first experience whatever symptoms? So if they, suddenly I was unable to talk and everything was blurry and what have you, when exactly did that start? Because within 3 hours, I mean, it's not exact, but within 3 hours, if we can get repair this or get blood flow back to this area of the penumbra, that damage is actually reversible. So for the most part, okay? So what's really, really important to remember about that is it comes up on a test. That penumbra is this area of damaged tissue just on the other side of the occlusion. If you see distal, it's just on the other side, right? To the occlusion that is potentially reversible. The key is time. We have to get to it within 3 hours and restore that blood flow so that we can interrupt this whole this whole cascade that we were looking at here. We want to interrupt it so that all of that isn't happening in that penumbra area where it's already happened in the core. It's too late for the core, right? So hopefully that all makes sense. Does anyone have any questions about anything we've gone through so far? We're good? Okay. So let's go on to types of stroke. This will definitely, right, Kieran, this will definitely show up on your exam. So understanding the difference between a hemorrhagic and ischemic stroke. It's really, really simple. A hemorrhagic stroke is a bleed. It's an active bleed. It's much, much less common than an ischemic stroke. But basically, instead of a clot forming, you have, usually it's an aneurysm that has burst. And has allowed blood flow to kind of pour out of those arterioles into the brain. So yeah, it's still going to stop some of the flow distally, but really what it's doing is you have a bleed into your brain, right? Very, very low percent. I think it's like 15% of all strokes are hemorrhagic. So usually we treat, the danger is you can't treat every stroke as ischemic. Well, we'll go over that. Sorry, I don't want to jump too far. This is the hemorrhagic stroke. Sorry, I don't know why that says 60% there. Sorry. Usually happens later in life. Usually the patients will have a history of hypertension, TIAs. TIAs, guys, are a huge sign of an impending stroke. So when people start to have TIAs, they are at high risk of having a full-on stroke. Okay, so that's usually something that comes up in an exam. They often occur, these hemorrhagic strokes often occur during sleep or after rising. The thing is, so if the patient already has hypertension, which usually they do, this kind of hemorrhagic stroke is almost always fatal. It's very sudden. People will often say, especially with like an intracerebral hemorrhage, that they had, people who've survived them, the worst headache of my life. So you'll hear people say, oh my God, I have this really, really bad headache. And you think, I've thought it, I'm like, oh my gosh, am I having a stroke? Because the headache is so bad. This kind of headache is like, it's beyond anything you've ever felt before. It's something very extreme. So I always tell my patients the chances of that headache actually being a hemorrhagic stroke are fairly low. It's a whole different kind of headache that you're experiencing. I'm not going to worry about this for you guys. Did you guys break down your hemorrhages into like intracerebral hemorrhage, subarachnoid hemorrhage? Did you need to know the differences between those? Kieran, do you remember?
I think we did. I don't know if it was in, yeah, we did. Yeah. You
did, okay. So if you remember this little, I'm just going to try to zoom in here. This is kind of a depiction of the layers of, the layers of the skull. Okay, so this here is like the skin on your scalp. This here is your bone, your scalp, right? So really the two main hemorrhagic stroke areas are your intracerebral and your subarachnoid. And it's really the subarachnoid that is the one that so if you look here, this is the subarachnoid space. Okay, if you look, it goes all the way through like this. Same on the other side. These are your two brain hemispheres, right? Your your cerebrum, and this space here is what's separating it from, like your brain, separating your brain tissue from this right here, which is your arachnoid mater, this layer right here. So a subarachnoid, sub always means under, so it's a hemorrhage that's happening underneath the arachnoid space. So you can see these blood vessels right here. This is what we're talking about. It's bleeding in through here. This is the kind of hemorrhagic stroke, the subarachnoid, where you're going to hear this. this, it was the worst headache of my life, this horrible, and then they happen so incredibly fast. It's often caused by an aneurysm. You guys know what an aneurysm, right? They call this like the silent killer because there's often no warning before this aneurysm bursts. It just bursts. The only warning sign you might have is this horrible, horrible headache. Again, that sign is that's your subarachnoid hemorrhage, this whole worst headache of your life thing. So, and intracerebral is just, it's actually in the cerebrum, right, in the tissue. I'd really, if they're going to ask you a question, I would think they would probably focus on the subarachnoid. It's just, I'm not even sure why. But anyway, so we've talked about this. Remember, we're talking about the two different types of stroke. First one was a hemorrhagic stroke, where the vessel bursts and bleeds out into the brain. We just kind of went through a couple of them, a couple of symptoms and what happens. And the other type, so we got hemorrhagic and you have ischemic. And ischemic stroke is it's the more common one. This is mostly what we're talking about when we talk about stroke, is when something has blocked the blood flow to a certain area. And this can either be a thrombus, and a thrombus is a clot. Thrombus is your thromb is relating to platelets that has built up in that arterial. Okay, so it's built up here on its own. Usually that will happen in the carotid, not in the brain, but usually in the carotid here. Okay, an embolus, on the other hand, is usually a piece of a thrombus that has broken off and traveled through the body to the brain and then has lodged itself into one of the arterioles that's feeding the brain. That can happen it just from other areas of the body. Now, usually not a DVT, because you guys, know that a DVT, right, when the DVT the vein actually feeds into the heart, right, not the brain. So I don't know if you guys have to go through all of these. So it is hard because a lot of this stuff wasn't in your slides, but it was in the textbook. So I just wasn't sure, like, if you need to know it. These are the kind of different kinds of ischemic strokes that you can have. Again, we've talked about a thrombotic and we've talked about an embolic. Usually a thrombotic is a large artery infarct, so it's not usually growing, it's not usually growing in one of these tiny arteries up here. It's usually, like I said, growing in the carotid. So that's why they call it a large artery infarct. So it's common in people with heart disease, with atherosclerosis, right, or peripheral artery disease. And again, it causes that complete cutoff of blood flow. So you can have a small vessel infarct where that happens kind of in the deeper part of the brain, but it's usually embolic. It's usually traveled from somewhere else and has, for example, if a thrombus has built up here in this area, it may not be big enough to block the blood flow through here, but a piece of it might break off and flow up and block the blood flow here, right? And so that's where you get kind of your small infarct. And then you will see this this cardioembolic infarct. Basically, it's just because the embolism is coming from the heart, right? It often happens with people with AFib who aren't on blood thinners, people who've had a recent MI, because the blood flow isn't properly moving through the heart. It's slowed down enough that those embolisms kind of form, those clots form there, but they don't lodge in the heart. They they exit and shoot up the carotid artery until they find a spot that's thin enough where they will set off a block. So it's kind of like these kind of types of ischemic, these are ischemic strokes, they kind of make sense. So like if you come up against a question, just think it through. What makes sense? If it's a large artery, it's probably going to be blocked by thrombosis, by something that's already been building. We don't see like clots necessarily building in the smaller vessels of the brain. That happens in other parts of the body, but not in the brain, right? Not often. Okay, so here's a big kind of subject, the TIA. So people often will call this a mini stroke. Oh, sorry, a mini stroke, or I've never heard anyone call it brain angina, but the textbook I think said that. Basically a TIA, it is a kind of a mini stroke. What happens is you have that clot. We've kind of talked about this already. Something has blocked that blood flow, but eventually, let's look over here at this this kind of guy here. It's a little easier. So eventually, it's blocked, but eventually it breaks down on its own. The blood flow maybe pushes it. It breaks down on its own, and because that area was only blocked. Let's go back here. We talked about how long can the brain live, right? How long can these cells live without oxygen? So it wasn't blocked long enough to cause this cascade to begin, right? And so you may have the symptoms. You may have the symptoms for a short time, but eventually the blood goes through. It doesn't permanently, and what I meant by that is it doesn't permanently cause this damage here. It's just causing like, okay, I'm not getting enough oxygen, so it's not working properly, but eventually it clears up. So really with the TIA, right, Kieran, like the big deal is just that it resolves on its own, and there are no evidence. There's no evidence after. You don't see long-term effects from a TIA. Like I said, people often have them and don't even know they had them.
Yeah, I would say the same thing. Like the only thing, to distinguish between it is it's short and there's nothing. It's reversible. Mm-hmm. And knowing that is important for the exam. I would say that I saw like one question on there that like just differentiating between it. Like my dad actually had a TIA. He came from India, and we saw him in an airport, and he looked horrible. He just had this ashy gray color to him, and we dropped him right to the hospital. So
right,
it resolves on the own. He did take ASA and everything like that. So
yeah, so that's the thing. If somebody starts having TIAs, they will immediately be put on some kind of blood thinner, because if you've had a TIA, it means that those clots are forming, and so we need to thin out your blood so that a stroke doesn't happen and cause permanent damage. Really, when we're talking, again, like Kieran said, if you see short duration and reversible, and especially no evidence of infarct. So you don't have permanent damage that was done in permanent symptoms of a stroke. As opposed to here where you have a minor stroke, where in the beginning, when it happens, in the moment that it happens, a TIA and a minor stroke might look exactly the same. You might have, exactly like Kieran said, like the person's pale, maybe they've got a droopy eye and a droopy mouth, or they try to smile and only half their smile smiles. That may happen in either one of these situations. The difference is that this one, when it resolves on its own, those symptoms go away. This one, this actual stroke, will cause you will see evidence that something has happened. Whether those symptoms kind of stick around, which often they do, but often if you've ever met anyone who's had like a minor stroke, you'll see it for like a few days or a week. My Nona, my grandma, actually had a very small stroke at one point. And like a week later, she was back to normal. But for that week, man, she everything on one side of her face was kind of drooped down. So you may not see here, you're not going to see any evidence for sure, right? You're definitely not going to see it on, for example, a CTA or an angio. Here, with a minor stroke, there is permanent damage. So you're going to see that damage on a CTA. And sometimes you will see those symptoms that hang around longer than if you have a TIA. So that's really the way you kind of differentiate them for an exam. And again, a lot of this stuff is very like black and white on an exam, and in real life it's a lot more gray than it is here. So when we're talking about diagnosing and managing a stroke, this is really the most important thing right here. First, as we've talked about that penumbria, we've talked about we need to get this within 3 hours so that that damage to this extra area around the core isn't permanent. We want to see if we can reverse that, right? Oops, sorry. But also we want to hit it, I think it's within in 4.5 hours. I think, yes. We want to start treating within 4.5 hours. This is where we can actually possibly make a difference. After a while, there isn't a whole lot that we can do, and that's why we do this, why there's so much education around how to recognize a stroke in the community, right? Because we need to recognize it quickly, and we need to get that person in and treated quickly. Now, if you look back at, sorry, I'm probably jumping ahead, but that's okay. If you look back here at these two different kinds of stroke, so you will see someone having those symptoms in the community. I think at one point they used to say, you know, to give the person some aspirin right away before. And you know, 85% of the time that would be the right answer. But the other 15% of the time, if the patient's having a hemorrhagic stroke, we don't want to give them a blood thinner, right? We don't want to make the blood even more thin so that it can. You guys have seen what happens when your patients are on blood thinners and you put an IV in, you take the IV out, and the blood is everywhere. It's just the same way in the brain, right? So we don't want to give any patient who may have a bleed in their brain any kind of blood thinner, so Clopidogrel, what have you. And so that's why immediately upon when patients come in to emerge with stroke symptoms, they go in as fast as possible for these imaging. Usually what they do is called a CTA. So a CTA is the same as a CT, but with an angiogram, so it's a CT angio. What they do is they inject a little bit of dye into the arteries that lead to the brain, and it's just like an angio that we do for the heart, right? You can see that dye going through, and right here you can see a really good example of an infarct, somewhere where the blood is not moving and not going through. So once we see it's an infarct and it's not, you know, it's not like, you know, blood spurting everywhere, it's not a hemorrhagic stroke, right away we can then start treating it as an ischemic stroke. And so, yes, obviously, really, honestly, when a patient comes in with stroke symptoms, the CTA is our most important aspect. Yes, they will have a 12 lead done, and that's to determine, okay, well, where did this stroke, maybe this stroke came from, like that clot that's came from an AFib or flutter, or possibly the patient had an MI and didn't know it. Patients have NSTEMIs all the time and don't know it. But this really isn't, as important as let's figure out if this is ischemic or hemorrhagic, because the treatment's going to be completely different, right? Yes, they will have their blood work done. We'll do PTT. We'll talk about that later. INR, all that. We'll talk about that in a little bit. This, like, obviously a lipid profile is not really that important in emerge, right? This is kind of like afterwards when we're trying to figure out how to prevent another stroke from happening. So let's go to manifestations first. So what will we see? You want to, again, when somebody comes in, and obviously I talk about emerge just because that's my experience. Patients will have strokes on other units as well, and people will have strokes in the community. So all of this is important no matter what. I'm only talking about emerge because that's my experience. So what you will see is, again, these motor changes, this hemiparesis. Again, half paresis is like a weakness. So they have this infarct here, happens on the right side of their brain. They will have hemiparesis and ataxia on the left side of their body, right? So they'll have trouble with movement on the left side of their body. They may have sensory changes, visual changes. A lot of people will say, like, one eye is blurry. The big one really is this speech changes, where they have difficulty speaking, difficulty. Dysgraphia is not speech. Sorry, I don't know why that's there. It's probably in your notes. Aphasia. And then, yes, this happens a lot, this kind of flat affect and apathy. I'm always like, how are you not more freaked out? But it kind of looks that way. So I will give you guys this mind map, because I don't want to go through all of these kind of like names, but you should be able to recognize them all. And again, if you break it down, you should be able to come up with what it means, just so that you don't want to lose an entire question just because you don't understand what nystagmus is, right? Actually, I don't think I didn't. Nystagmus is just the eyes kind of like jerk back and forth a little bit, just in case. The rest of them are all labeled here, so you can look at them later. So now the patients come in because somebody has caught it out in the community. They've caught this. They've come in. First, we're obviously going to do a very focused assessment. We've seen these symptoms. Now they've had their imaging done, and we have identified that they are indeed like having an ischemic stroke. What do we do? So immediately we're going to, so most emerges, for example, will have like these medical directives where you can just do this on your own. But even so, the orders come very, very quickly whenever there's a stroke patient. So we would give a loading dose of ASA or aspirin. If the patient is already on aspirin, which means that they probably are a high-risk patient, because if they're on aspirin already as a blood thinner, then they've already had problems with clotting, right? Then we will go to Clopidogrel instead. Quite honestly, most patients that come in end up getting either Clopidogrel or Ticagrelor or something like an anticoagulant. Again, sorry, I just said this, but if they're on ASA, we'll do Clopidogrel. And then, yes, they will be on ASA probably for the rest of their life. They usually do that 81 milligrams, or what they call a baby aspirin, every day. If the patient comes in and they're a high-risk patient, so they already have a history of whatever, they have a history of TIAs, they have a history of MI, they've already experienced all of these problems that have to do with blood clots traveling around the body, we want to hit them with a blood thinner as quickly as possible. So we'll give them a little bit of a higher dose, loading dose of Clopidogrel. Sorry. Often they will be on both ASA and Clopidogrel. Clopidogrel is just Plavix, in case that helps you guys. they could be on this for a month or so after. Usually they will end up on one or the other again permanently after, because we need to keep their blood nice and thin. There are some other things that can be done. We've talked about angioplasties when we were talking about our heart, like heart function and in the heart units. So it would be a very, very similar process here, where we would put in the guide wire, put in the use a balloon to kind of push, whatever plaque, if there's a plaque there, push it to the side. Sometimes if somebody's had an ischemic stroke that we've cleared with TPA or something, they might put a stent in after anyway, just to kind of keep the area strong. This endarterectomy, this would happen later after the emergency is over. They often would go in, and so say that ischemia happened up here in the brain, but it was because it broke off from a clot down here, right? We want to get rid of whatever's down here, and that can be an atherosclerotic plaque as well as a blood clot, right? So we want to go and actually surgically remove it, and that's just what an endarterectomy is. They actually cut in and just take the plaque out. Otherwise, if the clot is a thrombus, then we're going to treat it with anticoagulants and antithrombolytics. So there's a difference between those two things, right? You've got an anticoagulant, which is prevents coagulation, right? So it prevents clots from forming. Or you have a thrombolytic. And again, anytime you see lytic, we're talking about breaking or busting something up. So we're talking about busting up a thrombus. This is a question that comes up on every stinking exam I've ever had about stroke, knowing the difference between something that's going to bust up a clot and something that's going to prevent future clots from building. And you can easily tell the difference if you just are able to just break the word down and know, this one's against coagulation, this one's breaking up thrombus. So hopefully you'll be able to get that. So when we're talking about thrombolytics, yes, we also call them fibrinolytics. I've never actually seen that come up. Usually we call it a thrombolytic. The reason it might sometimes be called this is because it's breaking up that fibrin that's holding the blood clot together. If you remember from back in the day when we talked about, actually I think this was from the inflammation module as well. We talked about how the blood clots around some kind of damage. It clots, and then once it clots, those fibrin strands, right, come. Because of thrombin, they come, and it turns that fibrinogen into fibrin, and then it builds those kind of like spider webs, I call them, around the clots and holds that clot together. So if we can bust up that fibrin, we're going to loosen up that clot. So anytime really, these fibrinolytics or thrombolytics can be used anytime you want to break up a clot. The one that's used most often in the case of a stroke is a tissue plasminogen activator, or TPA. The medication is called Alteplase, but most of the time we'll just say TPA. So TPA is something that occurs already in the body. It converts that plasminogen to plasmin, which breaks down our clots. So it kind of works against that fibrin, this whole fibrin kind of thing here, because the body needs balance, right? So this Alteplase, or this TPA that we give, will mimic that. And again, what we really use this thrombotic for most of the time, though I've seen it used for, is in a stroke, sometimes in a PE. we use it often small doses to clear a PICC line. If you have a PICC line in, and I don't know if any of you have ever accessed a PICC line, but you know when you're trying to put the med in and nothing happens. I've had a student just like, you know, push harder, and I'm like, it's just going to explode. So we'll often use a small dose or a low dose of TPA to kind of to clear that. Let me just see here. So when we're talking about thrombolytics, really our biggest concern is bleeding. So not just before you give a thrombolytic, we have to look at this and make sure that they're not hemorrhaging, right? The patient's not having hemorrhagic stroke, is 100% is an ischemic stroke. And we want to monitor any other bleeding sites on the body. So if the patient has even just an IV in, right, that will come up sometimes on exams. You just have to like think about anywhere the patient might bleed, because that can obviously a TPA is really strong, and that can cause you'd be surprised how much a tiny little IV poke can bleed. The other thing I see often is I've had a patient who was on TPA. Oh no, sorry, they were on another blood thinner, but their nose started bleeding, and man, it was really hard to get that nose to stop bleeding. So I just want to see what's down here. So again, absolute contraindications, obviously is going to be a hemorrhagic stroke, but we want to be careful even if the patient has had a stroke or some kind of hemorrhagic kind of event in the last year. This is brain cancer, basically, or any kind of growth in the brain. Obviously, internal bleeding, and yes, Menzies does not count as internal bleeding. So, and then definitely a suspected aortic dissection, right? That's exactly what it sounds like. Your aorta is splitting down the middle. So we don't want to give them anything that's going to make the blood thinner and shoot out faster, right? These relative, so just so you know, all of these things that we're looking at are really just related to bleeding. They're just related to this. So you can pick this out on an exam, no problem. Even just somebody who has extreme high blood pressure, think about it logically. Like if they already have high blood pressure and you give them this really, really strong blood thinner, what's that going to do? It's not going to be pretty, right? And we sometimes will still have to, maybe not this high, but still have to give this to patients with high or chronic hypertension, because it's obvious, it's often this hypertension that has caused the stroke in the first place. So it's one of those like risk benefit decisions that you have to make in the moment. Again, history of a CVA or intracerebral, something, basically this all has to do with bleeding, right? If they're on Warfarin, we have to check their INR. We're going to talk about the difference between Warfarin and heparin in a minute. But you have to check their INR, you have to check their PTT, you have to know that their blood isn't already super duper thin, right? Obviously, again, if the patient is a hemophiliac or has hemophilia, we're not going to give them, or another bleeding disorder, we're not going to give it to them, right? One of the big ones that does come up is this head trauma. So we wouldn't give a patient who has any kind of recent head trauma a blood thinner, because they may have a slow bleed, right, from that. Everything else kind of just makes sense. We want to watch it really, really carefully for the first 24 hours. That's when the patient has the highest risk of bleeding from injection sites or some other kind of bleed. Okay, so over to, so we did thrombolytics. Let's talk about the anticoagulants. So this can be a little bit more, there's just a little bit more to it. So anticoagulants work by interrupting what's called the clotting cascade. So I put the clotting cascade here. This is nothing that you need to memorize or know. It's just really hard to, I mean, it's really easier to understand For example, the difference between warfarin and heparin, if you understand a little bit about the clotting cascade. So anticoagulants work by interrupting this clotting cascade in your body at some point. So because it's a cascade, you can interrupt it pretty much anywhere and it will stop the next step from happening, right? So for example, warfarin inhibits the synthesis of factor 9 and factor 10, and so that stops this from happening. So and heparin has its own kind of, it works on different ones. What ends up happening is that, actually, no, sorry, we've already kind of talked about this. So heparin, in the end, heparin ends up affecting this or inhibiting this 10A, which in the end prevents this thrombin from being released. And again, if you look at this thrombin, and the only reason this is important is because it helps to understand these. But heparin is stopping this or getting in the way of inhibiting this release of thrombin. And that thrombin is what's needed to turn fibrinogen into fibrin. If we don't have that happening, we don't have this kind of strengthening of these clots, and these clots are going to break down much, much more easily. When we look at dabigatran later, you'll see that it works directly on thrombin. So it does the same thing. It's just that in the clotting cascade, it works right here at the bottom, while heparin works on a bunch of these other kind of factors, okay? Warfarin was kind of one of the first line, it was like anticoagulant. It's what you will see a lot of your patients on. You've probably seen it already on warfarin as like a permanent blood thinner. We're going to talk about the differences between the two in a minute. It's really, the important thing to remember is that warfarin is used, an anticoagulant is used as a as prophylaxis, right? Patients will take it every day because they've had one of these things happen, and so we've put them, remember we said, sorry, right here, where they end up on something permanently, often that will be warfarin. Okay, so let's talk about, there's so much here. This is a big unit, guys. This is a really big unit, so don't be discouraged. It's a lot of information, but I think if we pull out like the really, really important stuff, which I'm trying to highlight, you should be okay with answering most of the questions. So again, we know how heparin works, right? We've talked about it. We've talked about it over here. Obviously, you're going to have a risk of bleeding, of hemorrhage. You can actually have an allergic reaction to heparin. Really, the biggest difference is what I was saying, that this is prophylactic. Heparin we use more in hospital, in emergency. I'm not going to go through the entire chart, but you guys will have a copy of it, so you can look at it. But it really, I broke it down as simply as I could to kind of match them. Like, for example, warfarin, you can only take PO. It doesn't come IV, you know, or anything. It's always PO. Heparin, you can't take PO. It only comes IV or sub-Q, and this is why we give it in hospital and often not in the community setting, although it's not unheard of. So I kind of tried to break it up so they were like on the same line. So again, this is a delayed onset. Okay, this is going to do nothing. Warfarin's going to do nothing for you in an emergency situation, nothing whatsoever. But heparin works immediately. So this is what we're obviously going to be giving in emergencies. That's everything except what gets a little bit confusing is this low molecular weight heparin. These are your, if you've seen it in practice, enoxaparin, dalteparin, your fondaparin, right? What these are is they are they're fractionated. So heparin comes in it's a very, very long kind of molecular chain. And what they've done, if you look down here in this little thing, these low molecular weight heparins, they've broken down this molecular chain into smaller pieces. So it's still there, it's still doing all of the same thing, they're just in smaller pieces. And the reason they've done that is because, yes, it lasts longer, but a big part of it is because it's more predictable. When we give heparin IV in the hospital, we have to monitor PTT like APTT like the whole time they're on it. It can be very, very dangerous. It's much more unpredictable. But the heparin that you give, these are the ones that come already in the little pre-filled syringe, and you just kind of pop them in their sub-Q. These ones are much more predictable. So we actually can use these prophylactically and do. Okay, so that's the only kind of little weird thing about, just kind of saying heparin's black and white, heparin's always an emergency, because that low molecular weight is used prophylactically. Often what we use it for in hospital is, well, really any patient who's going to be lying in bed for, a week, maybe post-op. Most of your admitted patients who are unable to move, or like they have mobility problems, will be on a low molecular weight heparin. And that's because, the blood pools and you're at a higher risk of clotting if you're lying around all day. So that's why we kind of use this prophylactically. In all other cases, your heparin IV is really your emergency blood thinner. Often, before we will initiate this, we'll send a patient for, especially if they're having stroke type symptoms, we'll send them for a CTA. We want to make sure, again, we want to rule out any kind of bleed, because yes, there's a huge risk of hemorrhaging. There isn't as much of a risk with these low molecular weight. They're much, much less risky. Mostly, if you look down here, what we're using for is DVT prophylaxis. DVT prophylaxis, like post-op. Okay. I just want to see if there's anything I'm missing out of this warfarin. You can take them both at the same time, and often do. So warfarin is something that patients will take at home, right? But it's a fairly, I wouldn't say unpredictable, but it's not as predictable as these newer. If you look over here, there's these newer like anticoagulants we'll talk about. And so because of that, we have to monitor the blood constantly. So people who are on warfarin, they go in and have blood work done regularly. And the way we measure its effectiveness is through their INR. And actually, let me just go over here. I think I have a thing to explain. I will. I'll go into that in a second. The only other thing to remember, and this is kind of obvious, but if the patient's having surgery, we want to discontinue their heparin or warfarin, right? These things are they cause a lot of bleeding. Now, if the patient is on low molecular weight heparin because they've been, sitting and waiting for their surgery, or they're just on it daily for prophylaxis, they can actually just stop at the day of surgery. So if they're having surgery at 4 o'clock, you can give it to them the day before. It's not going to affect the next day. But warfarin and like this kind of unfractionated heparin, you need to stop a couple of days. If you can, stop a couple of days in advance. Don't think there's anything, anything really big there. So this gets confusing. And I promise you, like, there are people who are at work who still get confused between this whole PTT, APTT, INR, and so on. So let's just go through it really quickly because this definitely comes up. So both warfarin and heparin are high-risk medications, so they have to have blood work done regularly. The difference is we use different things to measure that. Heparin is monitored using APTT, which is activated partial thromboplastin time, or PTT. The only difference between PTT and APTT, this is how we used to measure heparin. It just takes a little bit more time. So they basically, it doesn't matter. They did something to it to make it faster. So these two things, PTT and APTT, are both measuring thromboplastin time. One's just faster and more accurate. So that's why we use the APTT. And you can, if you look back here at the clotting cascade, you can kind of see why, but you don't need to know that, so don't worry about it. APTT levels, we want to keep within, so a normal APTT, I believe it's 25 to 35. Yes. So 25 to 35. That's just a normal person's clotting time. When we're giving someone heparin, we're giving it to them because we want their blood to be thinner. So we want that to be about 1.5 to 2 times their normal. So if the patient's normal APTT is 30, then we want to give them 1.5 to 2. So we don't want to exceed 60. That makes sense. This comes up, this is NCLEX stuff for sure. This will come up in NCLEX. I don't know if it'll come up on your exam now, but you should absolutely know, which measures, that APTT measures heparin, and right now we're going to talk about INR measuring warfarin. So again, warfarin is high risk, so we monitor that using the INR, which is your international normalized ratio, or PT, which is your prothrombin time. Really, an INR is basically PT, not PTT, is a PT, prothrombin time. The only reason we call it INR now is that for a long time, every country had a different kind of standard for their prothrombin time. So the World Health Organization was like, hey, let's make a standardized one, and they called it the INR. So they're really measuring the same thing. We use INR in real life. Your INR normally in a normal healthy person is usually around 1. When we want to, when a therapeutic dose, right? When we want to thin, we would have it between 2 and 3. If the patient's really, really high risk, we might have it around 3.5. Again, these things, these APTT and INR, are super important for knowing, how, for example, if you're sending your patient in for a surgery, you really want to know what their INR is if they're on warfarin before you send them in. I actually had a patient come into Emerge at one point with a perforated colon, and she was on warfarin, and when I checked her INR, it was like 11 point something. And then we had to get her up to surgery, but we couldn't send her up for surgery with an INR of 11.7. So what do we do? These have both heparin and warfarin have, I call them antidotes. I don't know technically what they are. Where did I put them? Oh, stink. Do you guys see them? Okay, doesn't matter. The antidote for warfarin is vitamin K. Because warfarin works, whoops, where am I here? Warfarin works, if you look up here, it works by inhibiting the synthesis of vitamin K. Vitamin K is needed to make these factors, these factor 9 and 10, and prothrombin, right? And this is why we measure prothrombin for warfarin. So if we want to counteract the effect of warfarin, we can give vitamin K. Now, it doesn't work really quickly. It's not really, like in that case with that woman who had an INR of like 11, we had to give this stuff called Octaplex, which actually is a whole different thing, and the vitamin K, because vitamin K wasn't enough. But for the purposes of your exams, vitamin K is your answer to a warfarin overdose, okay? Just, this will definitely show up on your exam. Vitamin K is an antidote for warfarin, and that's because vitamin K works by inhibiting vitamin K. Your like antidote for heparin is protamine sulfate. So you can just remember that. Vitamin K for warfarin, protamine sulfate for heparin. You just kind of have to memorize that. And knowing, you know, which one we're measuring. It's really, I mean, just remember warfarin is INR. Everything else is APTT, PTT, that's going to be heparin. This question comes up a lot on exams. You have a patient who's on warfarin. What should you, and they say to you, I'm really healthy. I eat a ton of green leafy vegetables. What is the nurse's best response? And the best response is something to do with you shouldn't be eating green leafy vegetables, because the green leafy vegetables are very, very high in vitamin K. And it actually will, as we just talked about, will counteract the effect of warfarin. So when a patient is taking warfarin, they shouldn't be eating a diet that's high in green leafy vegetables or high in any food that has vitamin K. I've just seen this green leafy vegetable come out on tests quite a few times, so that's why I use that specifically. So if you kind of, knowing what we know about warfarin and heparin, you kind of go through like these conditions, and it's obvious which one you're going to use. A DVT, for example, which is a clot that's growing in a deep vein, usually in the leg. In an emergency, we're going to use heparin. We want to get that thing treated quickly, right? Sometimes we will also use a thrombolytic, but usually we'll try heparin first. And then after, they're going to be on a low molecular weight heparin for prophylaxis, so that kind of sub-Q one that already comes in the syringe. And you can kind of go through these, and they all make sense. DIC, just for future reference, because it is sometimes an NCLEX question. I can't remember what it stands for. Anyway, it's basically when your body starts to make blood, like tiny blood clots all over the place, all in different veins all over the body. It's a major emergency, so we would use heparin for that. Valve problems and AFib, we're going to use warfarin, or oftentimes we'll use one of the newer anticoagulants. I don't know if you've gone through any of those, but even clopidogrel, but ticagrelor, which is Brilinta, or apixaban, which is Eliquis. One of those, or rivaroxaban, which is Xarelto, but one of those we will use. It's not always warfarin, but some kind of antiplatelet or anticoagulant. And these all we've talked about already. So on top of blood thinning medications for stroke, so we have a patient that's gone through all of that, they've survived their stroke, they're now on some kind of permanent anticoagulant, antiplatelet therapy. Obviously, they're going to have to make some lifestyle changes as well, and we do that through dealing with these modifiable risk factors. These are factors you've seen all of these before. I don't think there's anything new here. Always smoking is always bad. Hyperlipidemia, why? Because we don't want any plaques building up, right? That can break off and go into the arteries, carotid arteries. AFib, we want to treat these. Anything like this, we want to treat because we don't want blood clots forming. Again, that's any coagulation disorder. These are the big ones, though, like obesity, smoking, diabetes type 2, heavy alcohol use. These are all things we want to drop if you have a history of a stroke. Quite frankly, we know we should just be, these are risk factors for pretty much everything. And we should avoid them as much as possible. I think, yeah, I think that's actually everything. So I'm gonna post a copy of this mind map. I don't know if it will help. Yes, disseminated intravascular coagulation. Thank you, Kieran. I can never remember that DIC. So I'll post a copy of this. If it helps, great. If you prefer to study from the slides and from, your notes or whatever, that's great too. I just thought it was good to have like a different way of looking at this. Does anybody have any questions before we sign off? Any questions about anything that we went through? We can go through it again. You guys are good? Okay, awesome. So if you have a good handle on this kind of stroke stuff, it kind of bleeds into, no pun intended, it kind of bleeds into what we're going to talk about next week, which is brain injury. So that's really, really good. And then when do you guys have your first test this semester? If anybody's still listening. Week 5, okay. And then does it cover, it's going to cover 1, 2, 3, and 4? Darla, you don't, okay, so yes, 1, 2, 3, and 4. February 9th, okay. So Darla's asking when somebody has an ischemic stroke, how do you know whether to give an antiplatelet or an anticoagulant? You're usually honestly going to do both. Both are going to do the same thing. So I found that different doctors are, they like different meds, but almost all of them are going to end up having ASA first, and then, and then Clopidogrel. Honestly, Darla, there's no difference. Like it's not like, as far as I know, like if you give an antiplatelet, it's going to work differently in terms of a different kind of stroke than if you give an anticoagulant. They're both doing very, very similar things. They're stopping the blood from clotting. So either is fine, whichever is working better, oftentimes it's just whichever the doctor prefers. I have a doctor who always does ticagrelor. He just doesn't prescribe clopidogrel. And then I have other doctors who just Plavix is their go-to for everything. There probably are, there are differences, but for our purposes, you don't really need to know like the specific difference and why we're giving an antiplatelet here instead of an anticoagulant. We leave that to the doctors to make that choice, whichever they want to do. Yeah, no problem, Darla. Does anybody else have any questions? So I'm guessing then that your February 9th test is going to cover, if I'm right, it's going to cover stroke, brain injury, and then the 2 weeks you have on kidney function or renal function, if I'm right. So I'm actually going to try to put together like a thing of study notes for you guys that like not like a mind map, but just like how I study, which is basically I go through the textbook and I make a note on every single stinking thing that I think is going to show up on an exam. So I'm going to try, if I have the time, to make something like that for you guys for your first test. So it will cover like all 4 of those subjects. So Kieran, when you start prepping, actually, you know what? I'll just make them myself. That's fine. February 22nd. Oh, you've got lots of time. You're very excited about that, Hella. 23rd, 24th. That's great. Okay, that gives me some time. So I'll try to make those study notes for you guys. How are you guys feeling about this now? I'm gonna stop recording really quick here, and then